To keep on time, we'll get started. Today's talk is on age-related macular degeneration, and I'm sure everyone is aware of the basics with this condition. It is by far the most common condition we deal with as a retina specialist, and I'm sure in general practice it's also commonly dealt with. It is a degenerative retinal condition, of course, affecting the macula by definition. It remains the leading cause of severe vision loss in people over the age of 50 in most developed countries. Probably aware of two basic forms, and some of the terms we'll define here. The non-neovascular or dry form of AMD, of course, is the most common, affecting 80 to 90% of patients. Fortunately, because that's the less severe form, less vision-threatening form. But the more severe advanced form is the neovascular or wet form, affecting about 10 to 20% of patients, but accounting for, even now with our good treatments, still up around 90% of the vision loss with this neovascular variant. The general features are shown here. To establish the diagnosis of AMD, there has to be drusen. So drusen are the hallmark features, the yellow deposits under the retina of varying sizes as shown here. And with more numerous larger drusen, it's common to have some pigmentary clumping, pigmentary abnormalities, including RPE dropout or atrophy. A lot of times also people will use the terms early and late AMD, and early, of course, would be dry to a mild to moderate degree, and late would be either advanced atrophy affecting the fovea, causing decreased vision, or neovascularization. And untreated neovascularization will commonly lead to disciform scarring and therefore severe vision loss, and we'll go through this. To bring everyone back to the point of interest here, this is a disease centered around Bruch's membrane, affecting directly and indirectly the RPE, choriocapillaris, and outer retina. So this is the normal retinal anatomy shown here with a nice thin Bruch's membrane, nice healthy monolayer of RPE, and the photoreceptors interdigitating with the RPE cells, and robust choriocapillaris layer. But with AMD, there's diffuse Bruch's disease, diffuse thickening of Bruch's membrane, and I'll let Ralph Eagle go through the histopathologic details and pathophysiology, but over time what we're going to see clinically are the nodular excrescences, the larger areas of focal thickening of Bruch's, which are the drusen that we see here on the photograph, shown here histopathologically, and on the diagram, the local elevation of Bruch's, and having some initial impact on RPE, but not a lot functionally. And at this stage, typically with just drusen, as shown in this photograph, visual acuity is usually pretty good because there's no direct significant effect on RPE at this time. But as time goes on, with increasing Bruch's membrane disease, RPE dropout, death, of course, degeneration will occur, secondarily affecting the photoreceptors with photoreceptor loss and atrophy of the choriocapillaris. So all of these layers above and below will be affected as Bruch's membrane becomes increasingly diseased. And then at some point in the course of events in some people, we don't know exactly what triggers it, but with more advanced or more significant dry features, you're more likely to get choroidal neovascularization developing, and typically that's abnormal blood vessels derived from the choriocapillaris breaking through Bruch's membrane, invading the sub-RPE, subretinal space, and in the process, these neovascular complexes will leak fluid, blood, lipid exudate, and that's what we see clinically as wet AMD, and then unchecked, untreated, some degree of fibrosis is typical, the so-called late disciform scar. So going back to the clinical manifestations, here's a patient with early AMD. This is dry AMD at the very earliest stages. This patient would be expected to be asymptomatic on the basis of disease. So if this patient was 20/40, 20/50 and had 2+ nuclear sclerosis, you could probably just go ahead and take out the cataract because there's no way that's affecting their vision with these small to medium-sized drusen only and no obvious pigmentary abnormalities. So you should expect minimal or no vision loss at this stage. And this, by definition, is AREDS category 2, when there are no large drusen, just small drusen as shown here. Intermediate dry AMD is shown here, and there's a spectrum with a lot of intermediate-sized drusen as shown here on the left, to larger, more numerous drusen shown here, and by definition in the AREDS study, large drusen were greater than 125 microns in diameter. This is AREDS category 3. This is significant dry AMD. This patient's at significant risk for going on to more advanced disease and vision loss over time. And the vision may be impaired to some degree, and it's very hard to predict how much. So it's a common scenario to have this patient also have some cataract, and I'm sure both conditions are playing a role in their visual impairment. And then the advanced or late-stage severe AMD, again, is either severe atrophy affecting the fovea, causing decreased vision, or more commonly neovascularization. And this is a photograph shown here on the left that hopefully you won't see this much anymore, because anyone that's getting treatment now is highly unlikely to have such large, extensive disciform scarring. But that was the natural course of many of our patients not long ago. So the symptoms of AMD, of course, early on, not much at all. But in more advanced stages, either wet or dry, some or all of these symptoms could be present. And, of course, it's a macular condition, so you can expect some degree of macular dysfunction in the form of a relative central scotoma, reduced visual acuity, decreased contrast sensitivity, decreased color vision. All can be present, dry or wet. But the metamorphopsia is more commonly associated with the wet form. But an acute change, you have to assume it's wet, and that patient needs an evaluation if there's acute visual change in the setting of AMD. The risk factors are shown here. This is, of course, a list of both modifiable and non-modifiable factors. Obviously, things here we can't change: age, family history, gender, race. And some things we could potentially intervene or modify, such as smoking. That's a known large independent risk factor for progression of AMD. And a variety of environmental influences and dietary aspects of this condition that will potentially affect the course of the condition in these patients. So that brings us now to strategies of dealing with our patients that have AMD, the more early stages, in an attempt to reduce the risk of going on to advanced stages. Early detection is important. It does matter. And although we can't, quote, treat the dry form, that's what patients will say, that's what they'll hear, and that's true for the most part, although we do have a nutritional intervention. Early diagnosis is important so that the patient can in turn pick up on any neovascular transformation, which we can intervene, and all studies point to better outcomes with earlier detection of wet neovascular transformation. And that's how we can get good vision outcomes in our patients. But lifestyle modifications, it makes sense, although this is not technically proven. We have no prospective study that says you stop smoking, you start exercising, you eat better, your course of AMD is likely to be better. But it makes sense. And from a general health standpoint, of course, this all is important. If they smoke, stop smoking, exercise, maintain a healthy weight and diet, and along with a normal blood pressure, all potentially could have a beneficial effect on a patient's course. And then specifically with nutritional considerations, there's numerous epidemiologic studies and evidence out there to point to a variety of things we can do nutritionally for our patients, including a diet that's rich in leafy green vegetables, colorful vegetables, fruits, and so forth, that are highly likely to be beneficial for the patient. Now, when does that have to start? We don't know. Hopefully, we would imagine early in age would have the greatest impact. But what we do have, of course, is the AREDS study. Really the only study in medicine that's shown a positive effect from a vitamin intervention. And this is core important information. And I'm hoping that this is the last lecture I'm going to give on AMD that's only talking about AREDS 1, because AREDS 2 results are just around the corner. But AREDS 1 is an important study that you need to know. Of course, this was the study that proved that a antioxidant vitamin and zinc combination did decrease the risk of AMD progression and vision loss. And this was a large prospective randomized study that started back in the early 90s. And this is where those AREDS categories came from, 2, 3, and 4. These are the types of patients in which this intervention occurred, and that was a placebo versus the antioxidants of vitamins A, C, and E, and then zinc alone, and then the combination. And what this did show was a dose-dependent, that is, the combination fared the best in this study. The combination arm is shown there at 20% at year 5, with the risk reduction in terms of going on to advanced AMD, and also it was statistically significant decreasing the risk of severe vision loss. So it went hand in hand. And as you can see here, these curves stay separated throughout the entire course of the study, and this was statistically significant. Although in this study, they eliminated category 2 because the risk, if a patient had category 2, very mild dry AMD, the risk of that eye losing vision or going on to advanced disease was only about 3%. So they removed that group and only analyzed the AREDS categories 3 and 4, and that's what you're seeing here. And that's one criticism of the study because some people have questioned the validity of doing that, but nonetheless, everything else here is pretty strong, and most people believe this is important and real. So now, what do we do with AMD? Well, with the very earliest dry AMD that you might encounter, the so-called AREDS category 2 as shown here, with very small drusen, really not a lot. At this stage, we have no proof that an intervention will actually help, although it may make sense. So you might hear about people recommending certain things at this stage. We just don't have proof that that sort of intervention, whether it be AREDS or anything else, will help this patient because the risk of vision loss, again, is very low over a 5-8-year time frame. But nonetheless, some monitoring is needed for the patient in the AMD age group of 65 or greater. An annual checkup is probably sufficient. Technically, to be a purist, you wouldn't be recommending AREDS at this point. I wouldn't even bother with an Amsler grid at this point. But I would let the patient know there are some early signs of AMD, and don't attribute any vision change to anything else like your cataract or whatever. Assume, because you have AMD, that a vision change could be from it, and it has to be evaluated promptly. This is the more important patient. This is the AREDS category 3. So again, it's a spectrum of dry, moderate disease. And if one or both eyes look like that, as shown here in this fundus photograph, this is a patient that needs to know they're at significant risk. That risk could be 20, 30% or more of going on to wet AMD or vision loss over a 5 to 8 year time frame. And this is the type of patient that the AREDS intervention is important. And if they smoke, of course, though, you may have heard, of course, by now that vitamin beta-carotene supplementation in the setting of a smoker could increase the risk of lung cancer. So if the patient is a smoker, they are to use a modified AREDS formula without the beta-carotene. And most people substitute lutein, although we don't have proof that lutein has a benefit in this setting yet. But these patients need to be monitoring their own vision at home with an Amsler grid, and they should be checked, I would say, at least every 6 months. And any signs of a change, such as a blood spot, a lipid spot, anything you see or anything the patient reports should be worked up with an OCT and or fluorescein angiogram for detection of early wet AMD. So in summary, what we have for dry AMD, the good news is, although it's common, for most people it's not a problem, and for most people it will never be a problem. But we do have a nutritional intervention. We do have a treatment. And from a public health point, that can have a significant impact if you can lower the risk of combined AREDS categories 3 and 4 from 28% to 20%. That does have a large public health impact, especially for a relatively inexpensive intervention. So the AREDS formula is what we recommend in addition to dietary and lifestyle modification. But stay tuned, of course. AREDS 2 results are coming. They're coming this year, probably later this year. And AREDS 2 is looking at not only the base of giving AREDS, that's already been established with AREDS 1, but AREDS 2 is looking at some modification of the formula, a little bit less zinc, and they're also looking at lutein, zeaxanthine as a substitute for beta-carotene, and also looking at omega-3 fatty acid supplementation at about 1,000 milligrams a day. Some people think that may not be high enough because the cardiology literature, they tend to suggest benefits necessary at higher levels, but nonetheless we'll have some information about lutein, which is a question that patients have been asking for years, and also a little bit about omega-3 supplementation in this setting. There is a lot of research activity. We're doing virtually everything on this list here with at least one clinical study. There's a whole host of ways you could potentially intervene to help slow the progression of dry AMD, and that includes inhibiting the complement cascade to some degree, because complements have been strongly implicated in the pathophysiology of AMD at all stages. So complement inhibition might be beneficial. More recently, beta amyloid deposition has been detected in and around drusen. They think that might have a pathophysiologic role. So there is an antibody that it is administered intravenously in an attempt to draw out or decrease amyloid in tissue. Visual cycle inhibitors, there's some early initial positive results from a drug called fenretinide, and there's another more specific visual cycle inhibitor that we will be starting to test very soon. And then I'm sure you've heard of stem cell therapy. We have 2 of those trials going on here. So a lot's going to happen, but dry AMD is going to be a very challenging space. I don't expect to be talking about a new treatment for dry AMD anytime soon, other than possibly talking about some of the results from AREDS 2. But most of the things on the investigational side are only at phase 2. So we won't have a new treatment other than nutritional supplementation anytime soon. But the heart of our great advances and what we're doing for patients is in the realm of wet AMD. I understand this has been circulated electronically, this handout. This just gives a little bit more detail about what we do in practice in terms of how we manage our patients with wet AMD. And some of the important studies are also in here in this handout so that you have that you can read. But the signs of neovascular AMD, of course, a patient will usually have symptoms to some degree, usually, not always. So you can sometimes pick up on wet AMD with a patient that wasn't aware that anything was going on. Anytime you see blood, lipid, or fluid in the form of edema or subretinal fluid in the macula of a patient with drusen, you have to assume it's wet AMD, and that needs to be worked up. So this is neovascularization breaking through Brooks, as we showed earlier, and the diagnosis is typically confirmed or established. We will do a fluorescein angiogram at presentation in any patient that we suspect or see signs of wet AMD. And in your readings, you'll see terms. These are angiographic terms of neovascularization. They're not quite as relevant now as they were in the past with older therapies, but you'll hear terms like classic and occult, and then some mixture of the two. Basically, classic neovascularization shows up on an angiogram as bright, well-defined areas of hyperfluorescence that leak profusely. They tend to be a little bit more aggressive, faster-growing forms of neovascularization compared to the occult, which tend to leak less, grow slower. But they're all potentially destructive. They all have the potential to decrease vision, and we treat them all. OCT has become an invaluable tool, diagnosis, and in particular, monitoring the response to therapy, because an OCT will tell us the presence or absence of signs of exudation, particularly fluid at the various levels, as shown here. This is sub-RPE fluid, subretinal fluid, and macudema. There's typically one or all 3 areas of fluid in patients with wet AMD. So this is something we tend to talk and be most excited about, which is the great progress we've made in just a very short time frame, because for the longest time we had either no treatment for patients with wet AMD or laser photocoagulation, which had very little impact on the natural course of most patients. So it was it used to be core knowledge. I'm not quite sure you can call the macular photocoagulation studies core knowledge. I think for the time being we'll still say it for historical reasons and because occasionally we'll still use laser, occasionally. But the macular photocoagulation studies basically proved that laser could help some patients, again to a very limited degree, and I'll go into that. But it was just 12 years ago, around the year 2000, when the first non-destructive form of therapy came about called photodynamic therapy with the one FDA-approved drug, verteporfin or Visidyne. We could, for the first time, treat subfoveal neovascularization in the setting of AMD without making the vision immediately worse, which is what laser would have done. But it also had a limited impact, but nonetheless was a huge step forward. It allowed us to treat a lot of patients we could not or did not treat in the past. But the true huge advance came The pharmacologic or pharmacotherapeutic era was started just 6 years ago, around the year 2005. The first therapeutic, the first anti-VEGF agent was pegaptinib or Macular. It was short-lived, only about 6 or 12 months, because it was quickly supplanted by much more effective anti-VEGF agents, namely ranibizumab, which is Lucentis, and bevacizumab, the off-label use of Avastin. And then within the past year, we'll also show you the results of the third highly effective pan-VEGF blocker, which is aflibercept or Eylea. So now it's all about using 3 potent anti-VEGF agents, ranibizumab, bevacizumab, and aflibercept. But for historical purposes and through this timeline, I'll show you the treatments. So this is laser photocoagulation. It's heavy destructive confluent laser of the neovascular complex as shown here. This is the pretreatment fluorescein angiogram showing a juxtafoveal classic neovascular membrane. This is an immediate post-treatment photograph showing chalky white confluent laser. Essentially the goal is to destroy the neovascular complex. This is a post-treatment angiogram just a few weeks later showing absolute hypofluorescence in the area where the neovascularization has been ablated. Now, obviously, the most ideal candidate would be a patient presenting with a very small non-subfoveal lesion, which is a rare type of presentation. So the limits of laser is that, indeed, only a very small proportion of patients, less than 8%, have non-subfoveal CNV at presentation. Even that best-case scenario, as shown here, that's what this is. This was a patient that was treated, a small neovascular complex, pretty far from the foveal center. But even in that highly favorable scenario for laser treatment, there was a recurrence. And recurrence rates are high, greater than 50%. And almost always, this is the recurrence. It recurs on the foveal side. And any treatment into the subfoveal space with laser results in immediate permanent vision loss. And when the neovascular complex gets into the subfoveal space, there is vision loss that can't be recovered. So in steps the photodynamic therapy as a way to manage subfoveal neovascularization because it's a non-destructive laser. What this is a laser drug combination, a photosensitizing dye. In this case, the FDA-approved verteporfin is infused intravenously over 10 minutes with a 5-minute waiting period, and then a brief exposure to a non-destructive laser to the neovascular complex because the photosensitizing dye selectively collects in the neovascularization, and the non-destructive, non-thermal laser is used to activate the dye. It's a photochemical reaction. It basically causes selective clotting off of the neovascularization. It works. It was an elegant, brilliant form of approaching this disease. And it's what we did. That was the standard of care circa 2000 up to about 2005, 2006. So what did it do? Well, it didn't improve vision. In fact, this is the phase 3 pivotal clinical study for photodynamic therapy, the so-called TAP study. So in the most aggressive, fastest growing forms of neovascularization, the so-called classic form, that's what was shown to be effective. And what it did is it decreased the risk of vision loss on average. And so what you're seeing here is the natural history in the placebo arm, right here. Patients presenting here on average with 20/80, 2100 vision with new onset wet AMD. And the natural history, the placebo arm, would lose another 4 to 5 lines. That's the natural course of wet AMD. With photodynamic therapy, and this is therapy delivered about once every 3 months over the course of 1 to 2 years, and then you eventually tapered off as the neovascularization usually stopped coming back, you reduce the risk of vision loss. So it minimized the amount of vision loss the patient would have otherwise had. Unfortunately, of course, as you see here, it didn't improve the vision. So most people start with 20/80 vision on average, reduce another couple lines, and they're certainly better off than they were without treatment, but still not very satisfying end result visually. So photodynamic therapy was FDA approved in 2000. It's what we used. That was the standard at the time for classic neovascularization. It didn't seem to work as well for the slower growing occult variants. That's why it's only FDA approved technically for classic. It decreases vision loss on average, but doesn't really improve vision. And today, we use it very rarely, very occasional AMD scenarios, we would break out the photodynamic therapy laser. So it's all about pharmacotherapy right now, and what we're doing with pharmacotherapy, there's lots of different ways to attack the cascade of growth factors and events that occur for the activation of a vascular endothelial cell. Activation means you're activating an otherwise dormant cell normally to start to proliferate. And that's what these growth factors are doing, such as VEGF, vascular endothelial growth factors, and others interact with the vascular endothelial cell through the receptors on the cell surface, and we are neutralizing diffusible VEGF and other growth factors. That's the approach. It's the simplest approach. It's what we have that's worked, and you can use an aptamer, you can use an antibody, you can use a fusion protein. And you irreversibly bind the VEGF, preventing it from interacting with the cell receptor. Now, there's other approaches. You can interfere with this cascade downstream intracellularly, and that's been tried, but nothing else has panned out at this time. So what's VEGF? It's vascular endothelial growth factor. It's a family of glycoproteins that are freely diffusible and tend to be upregulated in the settings of local hypoxia or ischemia, and that is the theory. And what they do, of course, is they're potent stimulators of angiogenesis and vascular leakage. So VEGF injected in your eye or in animal eye, which has been done in monkeys and other models, will tend to cause retinovascular leakage. It will produce a picture that looks like diabetes, actually, but it can also promote neovascularization, either retinal or choroidal. And in this setting, it's choroidal-based. There are multiple so-called isoforms, which are different amino acid length variants of the VEGF-A family that we attack. So the first anti-VEGF agent to hit all of medicine was in ophthalmology, and that was Macular, pegaptamide. That's an aptamer, which is an oligonucleotide, and it was a very specific inhibitor of one isoform of VEGF, the VEGF-165, which is the most dominant, most common bioactive isoform. It's injected intravitreally every 6 weeks on the clock. That's how we used it. We didn't use it very long. What it did show in clinical studies was actually a bit of a disappointment. We expected more out of anti-VEGF therapy, and these curves look very similar to the photodynamic therapy curves. Although the drug worked for all neovascular subtypes, and we used it for all new wet AMD that came to us for a brief moment in time, you can see here in the clinical studies what it did is something similar to photodynamic therapy. It reduced vision loss rates. Baseline, you can see these are minus letters, and you can see the natural course, so-called usual care, was a mix of observation and photodynamic therapy. And it was statistically significant and led to FDA approval and use, but it still fell short of expectations. People expected something better than photodynamic therapy. So in steps, what we ended up using instead of Macular, because within 6 to 12 months of Macular's release, we had available to us these two potent anti-VEGF antibodies. There is the antibody fragment that was developed by Genentech for use in the eye and FDA approved for use in the eye. That's Lucentis or ranibizumab. And then there's the humanized monoclonal full-length antibody bevacizumab or Avastin, which Genentech tested and marketed and got FDA approved as an intravenous drug for the treatment of certain cancers in combination with chemotherapy. So they were developed simultaneously, and they came out actually around the same time, but Avastin came out a little bit sooner. And an investigator at the Bascom-Palmer Eye Institute started to use bevacizumab in the eye by injecting it in the eye. And so the complicated precedent-setting story unfolds that we as a field have been using both drugs in the eye for about 6 years or so. And so why do these drugs work better than Macular? Well, the reason is, now in hindsight, it's obvious that the binding sites for the antibodies are right here at the receptor binding areas of these various VEGF isoforms, whereas Macular was binding up here and really only blocking VEGF-165. And in vivo, plasmin will also cleave a lot of these VEGF isoforms into smaller fragments that are also bioactive that Macular would not inhibit. So basically, they inhibit all the isoforms and therefore worked better, more effective neutralization of all the isoforms of VEGF. And it became very obvious at early phase testing, as shown here, that Lucentis and subsequently Avastin was going to be completely different, and in a very strong precedent that we were seeing effects we had never seen before, which was rapid reduction in exudation and for the first time on average vision improvement. So this is an example of one of the patients enrolled in the phase 2 study with Lucentis showing the OCT after several injections with all the fluid going away, and this patient improved 17 letters with less leakage on the fluorescein angiogram at day 140. So Lucentis was being injected monthly, and we were seeing patients improving, which is something we'd never seen before. So Lucentis was tested. Lucentis, of course, because it became FDA approved for wet AMD, it had all the level 1 evidence to present that I'll show. And what is core information, of course, is the phase 3 studies for Lucentis, because they are the gold standard clinical studies for which we compare everything for wet AMD up till this point in time. And that's Marina and Anchor. And there are a few of these briefly touch upon the phase 3B studies with Lucentis to sort of set the stage of what anti-VEGF therapy, current most effective anti-VEGF therapy, can do. So the Lucentis phase 3 program consisted of 2 prospective clinical studies, the Marina and Anchor study, and as you see between the 2, it encompassed all forms of neovascularization. The Marina with the minimally classic and occult, and that had a sham control because photodynamic therapy didn't work well in that setting. And the standard for classic was photodynamic therapy, so this was a head-to-head study of photodynamic therapy versus 2 doses of Lucentis. And so Lucentis was injected monthly for 2 years with the primary endpoint in these studies at year 1. And for the first time, we have a wet AMD study that actually showed on average visual acuity improvement. And nothing has beaten this to date, but the Marina showed on average 6 letters. That's a little more than 1 line on an ETDRS chart. And Anchor showed 2 lines of visual acuity improvement. Look at the difference between 2 lines of improvement with monthly Lucentis versus 2 lines of worsening with photodynamic therapy. That's photodynamic therapy. That's what we were doing. And so this was very exciting, highly statistically significant, and for the first time we were improving vision. In this study, the primary endpoint was the proportion of patients losing less than 3 lines, because it was almost a given or expected that even with an intervention, patients were going to lose vision. But to our pleasant surprise, virtually no one lost 3 lines. Over 90% lost less than 3 lines from baseline with Lucentis injections, compared to the natural course of 50% or 60% with photodynamic therapy. And in terms of visual acuity improvement, now the focus has shifted. We're actually improving vision on average with this condition. So as you can see, with ranibizumab treatments, no vision loss or some gain occurred in 70 to 78% of patients, and about a third or so, up to 41%, were gaining 3 lines or more. So if on average you're entering this study at 2080 or 2100 and gaining 3 lines, you're going from moderate vision loss to pretty good vision. In fact, 40% of the patients in this study ended up 20/40 or better. It's remarkable compared to what we were living before that. So we knew from the very beginning, geez, monthly injections for life, that's going to be quite an impossible task for us and our patients. So there were studies that were launched immediately to look at less frequent alternative dosing regimens. And the first one was this phase 3B study called the PEER study, in which Lucentis was injected monthly for 3 months and then quarterly, once every 3 months thereafter. And you can see what happened is you backed off and treated less frequently. Unfortunately, you lost some of the vision gains. And this was compared to placebo, because this was launched at the same time as Marina and Anchor, so we didn't really have a new standard at that point. But early on in the course of wet AMD management with these drugs, Lucentis, Avastin, we recognized that 1, the disease is very, very heterogeneous, that 2, people responded very differently to these drugs. Some people responded very well, some people didn't respond well, so it was highly variable. And from the very beginning in clinical practice, we individualized therapy. No one treats these patients with monthly Lucentis or Avastin or whatever. So we individualize the therapy, and that's been the norm from the beginning. And what that means is sort of an induction followed by maintenance. Basically, we treat the macula until it's as dry or as good as it can get with frequent, regular injections, and then we back off. The so-called maintenance stage is either PRN, meaning treating when there are signs of recurrences, so watch and wait, or treat and extend, which is a more continuous form of therapy, which is now the norm. Almost 70% of respondents in a survey from the American Society of Retinal Specialists now show that they're using that individualized, more continuous form of therapy. So what treat and extend is you treat at every visit, but you're just extending the visits if the patients are doing well. But PRN therapy, or treating as needed, was first demonstrated to have a pretty good outcome in this small Pronto study. This was done by Phil Rosenfeld at Bascom Palmer with a mean of 5.6 injections in the first year. And this is very promising because this was saying that, look, we can get results that are as good as Marina and Anchor with PRN therapy, gaining 2 lines over 2 years with less frequent therapy. So that's great. And that's what we started to do. But this larger scale study performed by Genentech, in which the drug was dosed monthly at first and then PRN thereafter, didn't perform as well. But there's one big problem with this study. Patients were not followed closely. We've come to appreciate and realize the importance of very close monitoring. Without close monitoring, you can't pick up those recurrences quick enough, so patients would lose ground. Because every time you have a recurrence, you have neovascular growth, and you can't get the neovascularization to shrink up or go away. It's always going to be there. Once it grows, it grows. We can stop its growth. We can stop its leakage with these drugs, but we can't get it to really regress or go away. So that's why you get curves like this. Mean of 4.6 treatments over the first year in the large Sailor study. Didn't have results as good as Marina and Anchor. So this is PRN, and this is a little hint, this case example of why PRN may not be ideal for at least some patients. So this patient presents with 2200 vision. They're dosed monthly. You can see how quickly the patient gets better. Signs of exudation, almost gone after 1 injection, gone after 2 injections. So they're treated monthly, and then as soon as the macula is as good as it's going to get, perhaps, that's a judgment call, no treatment, right? That visit, that's month 3, 1 month after the 3rd injection. No treatment 20/30, but you can see 1 month later, all the signs of exudation are back and the patient's vision's down. So you treat here, good again, although not as good as it was before, 20/50. Didn't treat, and look, signs of fluid are back. And every time fluid comes back and neovascularization grows, you might have setbacks you can't completely recover from, and that's exactly what happened. Because by month 7, you've had several recurrences, and the vision is not quite as good as it was at its best. So that's why in some patients, PRN therapy may not be ideal. So again, going back to the year 2006, 2005 time frame, we had these 2 highly effective drugs, Lucentis and Avastin, and they both worked very well. And anecdotally, we thought Avastin worked as well as Lucentis, but that had yet to be put to test until the CATT study. And I'll say this is also core information because Marina, Anchor, CATT, those are the big studies you ought to know about. So CATT was very important, but in hindsight, it didn't really change much in terms of what we did. But what it did do is more or less proved our impressions to be correct for the most part. So this study, 4-arm study, compared Lucentis to Avastin. So that was one question to be answered. Are they actually comparable? And 2, compared monthly therapy to PRN therapy to see if that's a comparable way of managing the disease. So there are the 4 arms. Lucentis, Avastin monthly, and Lucentis and Avastin PRN with an outcome of mean visual acuity change at 1 year. And here are the results. You see on the left, this is the mean number of treatments. Of course, the monthly arms are 12, and the PRN arms, about 7 to 8 treatments in the first year. And the dotted lines are the PRN arms. And they look pretty good. In fact, for the most part, the PRN arms were non-inferior to the monthly arms. So with frequent monitoring in a PRN setting, you can get results that are pretty close to monthly therapy. It was good news for the most part. But that trend right there was a little concerning as we saw it dip down. And it's kind of pointing to what I mentioned before, that PRN may not be ideal for all patients. And in fact, by year 2, those PRN arms slip down a little bit more, and you can see the difference is a little bit greater. And those are the mean number of treatments over 2 years, 22, 23 in the monthly arms, 12 and 14. So we can say that PRN therapy with close monitoring gets you results that are close to, at least in the short run of a year up to 2 years, close to monthly, but technically not as good. So that's why, and even before the CATT results, we had already been shifting more towards this more continuous treat and extend approach. And this is an example of treat and extend therapy. So this is the patient at baseline with occult subfoveal neovascularization, 2100 vision, and obvious signs of exudation on the OCT. And treat and extend means we're treating regularly and frequently, monthly here, until the macula is dry. And once it's dry, we treat and then say, okay, see you back in 6 weeks rather than 4. So this is 6 weeks later. Looks good, treat, come back in 8. Looks good, treat, come back in 10. And that's 10 weeks after the last treatment. You can see the recurrence. So we treat, say, come back in 8, cut it back. And there they are at 8. And we maintain this patient dry thereafter with a treatment once every 8 weeks. So it's certainly better than once every month, but nonetheless, it is a constant, continuous treatment. And we published some of the earliest studies. They were retrospective studies, but nonetheless, with both Lucentis and Avastin, we're able to demonstrate in these small-scale retrospective studies results that were comparable to Marine and Anchor of continuous monthly therapy with a treat and extend approach, averaging about 7 to 8 treatments in the first year. So you can see now, looking back at all these studies, the monthly administration of Lucentis in the Marine and Anchor will gain you typically 30 to 40% 3 lines gained with good stability. In the CATT PRN arms, it was pretty comparable, 25 to 28%, and that's with either Lucentis or Avastin. And then the treat and extend approach, you can see that it's similar numbers of treatments in the first year. So what this is basically telling us is, on average, these drugs are good with every 6 to 8 weeks. That's what's needed to get good results and keep the macula dry. And then now, within the past year, we have a third anti-VEGF agent that we're using, and that's aflibercept, which is a fusion protein, otherwise called a receptor decoy, which essentially is doing the same thing. It's binding and neutralizing extracellular or freely diffusible VEGF. So aflibercept is the former name VEGF trap, that should be an F, VEGF trap. It is also a potent binder of all the isoforms of VEGF. In addition, it blocks placental growth factor. Whether that's important or not, we don't know, but that might also be playing a role in the pathogenesis of neovascularization. And at first we thought it was a little bit stronger in terms of its binding properties, a little longer half-life. Maybe it either works better or lasts longer. And in phase 1-2 testing, you can see a single dose showed an effect that looked pretty good out through 8 weeks. Now, that's not to say you can't get that with Lucentis or Avastin, because you sometimes can. But nonetheless, what they did in this study, the phase 3 study for EYLEA, called the VIEW studies, it was a head-to-head study of EYLEA versus Lucentis, testing several doses, VEGF trap, that's what VTE is. 2 milligrams, 0.5 milligrams is the standard, of course. Lucentis, 0.5 milligrams, that's what's commercially available. Monthly for the first year, but they added this fourth arm, which is the higher dose of EYLEA, every 8 weeks after the loading dose. So that turned out to be 8 treatments in the first year. And no surprise, you could have guessed the results. All the arms looked more or less the same. So this study proved that EYLEA works as good as Lucentis, whether it's dosed monthly or with the high dose, which is commercially available, every 8 weeks after the loading. And so that's what we have. We have a new drug that works as well as Lucentis. And whether it lasts longer or not, we can't really say. We can't really tell based on the way this study is designed. In year 2, all arms went PRN, so you see a little dip down, but still pretty good vision outcomes. And the mean number of treatments in all the arms were pretty close, a little bit less with EYLEA. So again, leaves us with that impression that EYLEA may last a little longer. So for neovascular AMD, where we are now, is it's all about monotherapy. We're using one of those 3 drugs injected intravitreally on a regular basis. And that's going to either be ranibizumab, which has been available now for about 6 years, FDA approved in 2006, aflibercept, which was approved a little over a year ago, and bevacizumab, which remains off-label, the way we've been using it, and that's been available and been in use since 2005. So that's what we have, and the way we use it is either in a PRN or more commonly a treat and extend fashion. We follow these patients closely, and that's a burden for all people involved, certainly our patients. This is not a cure. This only can control the disease, so this is an indefinite time frame. So patients, especially younger ones, that's a big deal. To present a patient at 65 with the notion that they'll be getting injections on a regular basis with regular follow-up for another 10, 15 or more years of their life. And this question remains of whether aflibercept lasts longer. Most people have the impression it might last a little bit longer, but not a lot longer. So in summary, certainly this area has evolved greatly over the past decade, particularly in the realm of wet AMD. For dry AMD, there's not a lot to do right now that's different than what we've been doing for the past 10 years. It's all about the AREDS 1 vitamin supplementation and some lifestyle modifications, counseling, disease monitoring. And that's both what we do and for the patient at home, especially the high-risk patient. But for wet AMD, there's been huge changes. For non-subfoveal CNV, I generously put 10%, but it's probably more like 5 or 8% at most. We sometimes still use laser. That might be the peripapillary neovascular membrane, for example. Something far away from the foveal center will sometimes break out laser. So you will still occasionally hear about its use. But for most patients, up over 90%, it's anti-VEGF therapy alone. And I would still say, because of the testing, extensive testing in years that we've had Lucentis under our belt, it's the gold standard anti-VEGF agent, with Avastin looking comparable in terms of efficacy and safety, although that aspect of things hasn't technically been proven. And Eylea, you can certainly say, is equivalent to Lucentis in efficacy. People will present a case here and there where it may look to be better or more effective. For the most part, as you can see from the clinical studies, it's equivalent, and it may or may not last longer. But the future, and the future is in the near future, because a lot's happening still right now. We're on the verge of testing one of several prototypes of a sustained release device that you place in the OR, and then you can refill. This is with Lucentis, refill every maybe 4 to 6 months. So that would help to decrease the burden of anti-VEGF therapy in terms of our frequent injections. There are newer VEGF blockers that are being tested. One in particular is in a new class of molecules called DARPins. And it's looking like we're getting a longer duration of action. It could very well be a 3 to 4 month injection, which would be great. We've been talking years about combination therapy, just like our oncology colleagues, the approach to cancers, where we're using different agents with different mechanisms of action. And one thing that's showing actually pretty good promise in phase 2 testing is another growth inhibitor, an anti-PDGF, platelet-derived growth factor molecule, and combined with anti-VEGF therapy. Anti-VEGF therapy is here to stay for a long time, no less than, well, we'll say the foreseeable 5 to 6 year time frame. VEGF therapy is the mainstay, the gold standard foundation therapy. Whatever else we do is either going to be added on top of it or some variation on the theme of continuous anti-VEGF therapy. And then we hope to see some dry AMD therapies without anything right now in phase 3. Is no less than a 3 to 4 year time frame. The visual cycle modulator, it's an oral therapy that we're going to start testing next month. That technically is a phase 3 study, so that could very well be, if it pans out to be effective, the first new dry AMD therapy. So a lot's happening both in the realm of wet and dry AMD still from a research standpoint. So I'll continue to modify this talk on a frequent and regular basis, and hope to deliver many more updates over the next few years. Thank you, and any questions? Yep.
Thought why the Marina and Anchor had pretty different results when they're both done monthly with the same dose of Lucentis?
That's a good question. So the Marina was mostly occult and some minimally classics, which are slower growing, and Anchor is faster growing classic lesions. And the faster growing classic lesions tend to have more exudation associated with them. So one thought or one explanation would be they had more signs of wetness. And if the drug is, for the most part, giving you a visual benefit, mainly by reducing or eliminating the wetness, there is more to work with classic. And it could very well be that it's a patient population that allows for a greater visual acuity improvement potential. So that's one thought. Faster growing. And in fact, classics tend to show up, present sooner, smaller lesions, and smaller lesions, regardless of the lesion subtype, do better. Less area of destruction and better, more likely to have vision improvement. Cults tend to be larger because they're sort of brewing there slower, and they tend to present later for patients. Anything else? Yeah.
Do you think that after the CATT trial, do you and your colleagues use Avastin more, feeling more comfortable with it, or did it just sort of confirm the previous treatment plans?
Well, up until the point of the CATT study being conducted, our field in general was already using a majority Avastin use, 60-40. So up until 2 years ago, it was about a 60-40 ratio of Avastin to Lucentis use in the United States. And since then, it may have increased a little bit. It didn't really change people's impression. Why do some people use Lucentis? There's a whole host of reasons, and it's very complicated. But having the FDA label and the medical legal aspects of that is one thing. There's also theoretically the argument that Lucentis could be safer than Avastin. These drugs we're administering intravitreally. They do, however, get into the system. And there is the potential for systemic side effects. Now, they didn't show up in these clinical studies, but a lot of us believe that there are some systemic adverse events that are occurring at a very low level, sort of flying under the radar, that you can't pick up in these studies that have only 300 or 400 patients in an arm. You would need thousands of patients in each arm to see any safety differences because the event rates are so small, so low. So what are we talking about? We're talking about strokes, heart attacks, thromboembolic events, and hemorrhaging. Those are known anti-VEGF systemic side effects that occur when you use Avastin systemically. So a lot of people feel that Lucentis is potentially a safer drug because it's much faster cleared out of systemic circulation. The half-life in the plasma circulation is hours for Lucentis, but is days with Avastin. So Avastin may linger a little longer and theoretically be less safe. But that being said, they are comparable for sure in overall safety profile.
Are there any studies or is there any data out there that confirms whether or not PDT combined with anti-VEGF therapy can either extend the period between treatments or decrease the decline that you have over 2 years?
Sure. In fact, that was a hot area of study just a few years ago, and I didn't mention it because it never really panned out. So there have been prospective studies looking at the combination of photodynamic therapy plus Lucentis, and it's very logical. It made a lot of sense. In fact, a lot of people, not a lot of people, but some people were doing a lot of it, a lot of combination therapy on a regular basis for exactly that reason. They weren't expecting better vision results, but they were hoping to, by again combining treatments of different mechanisms, hoping to get at least a greater durability of effect of the two combined versus monotherapy Lucentis or Avastin alone. And the studies, unfortunately, did not show that it allowed you to cut back or reduce the anti-VEGF therapy. And in fact, one study showed the combination arm results, vision results, didn't look as good. So that made people back off pretty quickly. So it could very well be that although we talk about photodynamic therapy as non-destructive, the fact is it's not completely selective, and it is possible that it does a little bit of damage that we didn't recognize when we were treating eyes that had much more severe disease. But now that we have eyes that are seeing much better, it could have an impact negatively on those types of patients. So we don't really use photodynamic therapy much anymore. There are some neovascular subtypes, like the polypoidal choroidal vasculopathy form of neovascularization that appears to be pretty responsive to PDT. And in the Asian populations and in countries like Japan, they use a lot more photodynamic therapy. But here we use very little of it, mainly for refractory cases or cases that don't seem to be responding completely to anti-VEGF therapy. We'll sometimes add in photodynamic therapy for some added additional control. Very good. Thanks for your attention.